might be thinking to yourselves, what is full matrix interoperability testing? And hopefully by the end of this presentation, you'll have an idea about what we're talking about. My name is Timothy Bennett. I'm the Director of Strategic Healthcare Initiatives at the Drummond Group. And I'm joined here by Michael Gould of ZeOmega. Michael, you want to introduce yourself?
So good afternoon, folks. I'm Michael Gould. I go by Mike from ZeOmega. ZeOmega is a population health company. We do care management. We're awarded by class as a care management company. I'm focused on our interoperability practice, things that are general interoperability, but also regulatory compliance. And ZeOmega is also certified by Drummond for our patient access and provider directory and other interoperability solutions.
Yeah, just a little bit about Drummond. We've been around for 25 years doing interoperability testing. And starting in 2010, we became a ONC test lab and certification body for their certification program. And so we're bringing many years of experience to the testing and certification and interoperability space. So I'd like to say, have the stakes ever been higher for FHIR as they are now with the emergence of, some of these next wave of FHIR use cases and implementation guides? FHIR is kind of in a spotlight right now where they have the potential to really bring some impactful change to the exchange of health data and help reduce costs and burden to providers and payers and patients as well. So there's been a number of federal regs over the last few years. Currently, the most recent one out is CMS's Final Rule 0057, which was published earlier this year. And that introduces FHIR-based prior authorization, payer-payer data exchange, provider access. And we're expecting, more regulation around the No Surprises Act, patient cost transparency, so patients have the ability maybe for the first time ever to really know what the true cost of a medical procedure is before having it done. But that requires a lot of conversations between perhaps many payers and many providers and a payer, all potentially with FHIR technology behind it. And even before that, ONC has supported FHIR technology through its own rulemaking with the Cures rule and then HTI 1. And we know they're working on HTI 2 now, which most likely will have prior authorization requirements in the provider requirement too. So, Michael, let me just ask you, as a developer of FHIR solutions with customers who are subject to, this federal rulemaking, what's your perspective on the challenges of that, and particularly with testing?
Well, the first thing is we're in an unprecedented era where we have multiple rules that we need to adhere to. So having the understanding of the various CMS and ONC rules is important to making sure you can at least check the boxes. But it's also a matter that some of the effective dates or the required compliance dates are perceived to be in the future, but they're actually next year, the year in between, and the third year in 2027. So you actually have to get started this year, 2024, without delay to start implementing, testing, and partnering with other organizations that make interoperability happen.
So, we all know that we need FHIR products to be interoperable, in the field, especially with the stakes being high with some of these, emerging, implementation guides is going to help enable prior authorization and other ones. But, currently, I don't think we, my belief and my opinion is we don't have the testing methodologies and mechanisms in place to right now to really make those kinds of interoperable products a reality in the next few short years. The journey towards interoperability kind of starts with having good FHIR IGs and reference implementations, and then test tools and test scripts that and connectathons where developers and implementers like Michael can bring their products and have some of the first chances to test it with other products. But they have their own ways of doing self-testing, and eventually, though, perhaps there's some conformance testing options either through ONC or through a Drummond program like we stood up for the CMS 9115 final rule for patient access. But even all of that together is not going to be enough to guarantee interoperability. But Michael, why don't you comment on why your company thought going through conformance testing was important, and what you kind of even see as the not quite drawbacks, but why that isn't quite enough.
Right. So turning back a couple of years, when FHIR was still relatively new, maybe in its midterm, it's okay for us to implement and attest or claim that we adhere or conform to the standard, but having a third party actually test that and validate and verify that we are conformant is really important, because we can go out and try to implement FHIR apps and APIs that may or may not work with one or another client if there's not the rigor of verifying conformance that a third party gives us.
Yeah. So there are reasons why those, the testing that we've talked about before is not quite enough. It's a very necessary part of the journey, but there are limitations to that. I mean, developers, from one developer to another, they can misinterpret the spec, and it's only when you sort of test together or do conformance testing that you maybe possibly discover that. Connectathons themselves, while they're important, they're limited in scope. Typically, they're limited in the participants that come, and there's really just not enough time to get a lot of testing done in a weekend, which is typically the length of them, maybe at best a week.
Right, and that's why we've adopted a process, not a formal process, but one where we start connectivity and testing well in advance of a connectathon effort. But we've also continued after the connectathon effort in a continuum, because we found that partnering with organizations to do that is more fruitful than just showing up for a weekend and saying that you did it.
So, Michael's talking about some continuity of testing that it's not just a single event, but that it happens sort of over time. Even though conformance testing, though, while also is important, it still doesn't guarantee, interoperability in the field. And the last thing you want to do is discover your interoperability issues after you've deployed your product in the field, and now you've got to, work with your customers and which you probably have.
Absolutely. Our product line is not a static thing. We have various versions and releases of our products, and things can change from one release to another that affect the conformance. So having a continuous cycle of conformance testing ensures that as we progress along maturity of our products that mirrors the maturity of FHIR Implementation Guides, that we are indeed staying conformance. And again, that's validated and verified through a third party.
Right. And so, just some lessons learned from Drummond Group's own certification program around the CMS 9115 rule, which ZeOmega was a participant, and others were participants in that as well, that every developer that brought their product to do conformance testing, not a single one was compliant when they began testing. Everyone found issues. Everyone had to fix things, and so therefore, there's really no reason to believe that the products that are out there deployed in the field that haven't been tested and certified by independent third parties, there's no reason to believe that they're fully compliant, which means that there's non-compliant, FHIR products out in the field deployed, no matter what that developer may tell you when they're trying to sell their product. Until you go through the testing, until you can prove that you're compliant, it's a best guess. And Drummond's even gotten feedback from consumers of FHIR APIs that essentially say that they are finding in the field non-conformant FHIR implementations. And so I don't know if you have any comments to that or not, but
Not really. We haven't experienced too much of that ourselves, but it's still early in the game. And with the expanded requirements and the new interoperability and prior auth rule, there's certainly going to be evidence for more conformance testing.
So, before Drummond got involved in health IT testing in 2010, beginning in the early 2000s, Drummond was involved in helping write some of the first implementation guides, which were called applicability statements with the IETF, on these emerging internet standards at the time, to enable businesses to move off of private networks as trading partners in the B2B supply chain space, financials, automotive, whatever, those types of domains, and began to use the internet to exchange secure business documents. And these applicability statements, these implementation guides, if you will, would describe how to use the SMIME standard, HTTPS, X509, PKI, digital signatures, encryption, a stack of standards together to describe how you go about doing these use cases. And Drummond established at that time some interoperability tests around that and brought product vendors together. There were competitors in the market to test each other, with one another, to confirm interoperability of that. And what we discovered during that time is that conformance testing alone probably only got you 85% of the way to interoperability. It was only when you actually brought the products together, testing with each other, and discovering the last bits of interoperability issues that those whole domains of business could become interoperable. And we've continued those tests, now for 20 years. So we're still doing those. And so now we feel like, Drummond is positioned to help facilitate bringing these full matrix, that's what we call full matrix interoperability tests, where all of the products are together testing with each other, playing all the different roles as sender, receiver, whatever, that the IG requires, in a scalable and reliable interoperability test. And so we're happy, that we're announcing that we're, moving forward with doing that for payer data exchange, starting with a pilot. ZeOmega is going to be part of that here in 2Q. And I don't know if you want to, speak for a moment about why you think that this full matrix interoperability is the idea for the time.
Yeah, it's important that, as you said, competitors even come together to test together, because take for instance, we're here at this conference with a large exhibit floor. How many of our products actually do interoperate with each other, right? And some do, some don't. Some do to a reliable degree. Some do it to a less reliable degree that may be case by case based. But one of the things that we like to think is that by virtue of conforming to the FHIR standards, that we can be pretty much agnostic to any particular company's implementation of things so that we could be interoperable. But that still needs verification in the real world case.
Right. So this diagram here kind of shows a picture of what full matrix interoperability looks like with many different products coming together, and they're doing the full gambit of testing from a test plan and test cases. Now, back in the B2B days when we do these, we had upwards of 30 different products testing with each other. That's a pretty big matrix, and that could take a lot of effort. If you were to sit down as one developer and now I've got to test with these other 29 other products, how much effort that's going to take? Well, it really has to be an automated system to help drive that, or it's just not really scalable or realistic that you can get any testing together. And so, that's what Drummond is proposing that the market and the industry needs is a way for these FHIR products to come together, and we be able to use automation to drive upwards of thousands of tests between a large matrix of partners. And if we're going to expect that prior authorization is going to work when it's supposed to go live at the beginning of 2027, and you haven't done this sort of testing between EHRs, between payers, of which there will be many in the field, I think that's just that's just
it's a recipe for disaster.
It is a recipe for disaster.
And we won't achieve the intended outcomes that CMS set forth in their rule.
Absolutely. I mean, and CMS wants that too. So, so that's the platform that we're talking about. It's an automated test orchestration system, that sort of implements this, test plan and all the test cases with it. And, it's going to support being able to, trigger these products to test with one another, however many tests that takes, thousands, whatever.
And automation is important, and it's essential there because as a product company, we need to keep our focus on delivering the product, supporting the product, improving the product, enhancing it. And testing and certification at this level is not an option. It's going to be required for interoperability to be real. So we don't have infinite resources at my company. Drummond doesn't have infinite resources. So employing automation gives both the augmentation, but also the auditability of the certification.
Yeah, and that's right, because with the automation, it can capture the results of all the tests. And, so you have the history of that, and you have ultimate proof, as people discover their interoperability issues, fix them, and then do retesting until, the whole matrix of products show that they're interoperable with each other. The output of these interoperability tests will be for the market a list of products with versions that are interoperable with each other. And there's nothing like that in the marketplace right now for FHIR. There's no place a buyer can go to and say, with confidence, if I purchase this product, I know that it's interoperable with my other payers or these other EHRs, that I know that it's going to work for prior authorization or for patient cost transparency or payer data exchange, whatever. And and that's something that the marketplace needs, and some confidence that that we truly have interoperable products, not just ones that we say, well, we've done some conformance testing on and they should be interoperable in the field, but there's actual hard evidence to show that it is.
We wouldn't accept the fact of, Tim, with an iPhone, that you couldn't call me on my Android phone. Nonetheless, we shouldn't accept the fact that interoperability is limited to certain products and not a fuller matrix, a wider community of FHIR implementers.
That's right. So, if you're a developer, we're encouraging you, to contact Drummond. We'd love to talk to you about full matrix interoperability testing and helping to unleash its power. So, at this point, we'll open it up. If there's questions from anyone, we'll be happy to, entertain those.
Anybody else out there interested in doing full matrix testing? It does require a community of testers, a community of people committed to conformance and going beyond conformance. So certainly speak to Tim about joining that community. And don't be bashful. It's okay to make mistakes. We've been there, as Tim mentioned, when we first went for our certifications with Drummond. We didn't pass on the first try, but we got the feedback from the testing and we improved our product.
Yeah, and as Drummond is a sort of a neutral third party, the thing that we did in the B2B space, and we intend to do here in the FHIR space, is create a safe space for competitors to come together and be able to make their products better, make their products interoperable, without concern, that someone is going to, see behind their curtain or whatever. Everyone's going to our experience is everyone has issues. Everyone will have things to fix, and everyone's sort of in the same boat. But having, a neutral third party that sort of, sets a safe space that, kind of keeps everything in-house, and with the goal of, creating interoperable products, I think it's something the market, also needs. Any questions? We good?
One other comment I just want to add here is that this is moving forward from conformance testing, as you mentioned earlier, into a realm of real world testing. And there's another corollary that I'll make, is that in pharmaceutical research and development and marketing, they bring products to through research and development, test them along the way. That's why we have the FDA. But even after the product is released on the market, they have to do continuous monitoring and testing as well. So I like to liken this to something like that. But hopefully, no one has to be sick to buy, such products.
All right.
I have doubts about your characterization of the matrix, not the film matrix, but how do you see the matrix? Is it a matrix of all the products against all the products, or it's roles against roles, or it's roles and test cases against roles and test cases? Which is your how is the matrix? What is look like the matrix?
Yeah. So there will be a number of test cases in the test. Could be 20, could be 30, could be 50, whatever the IG or IGs call for. And the matrix is the products, if you will, the rows and column is the X and Y axis are each of the products testing each test case with each other. So there was a row for each test case, and the products test each test case with each other. Each product tests each test case with each other. And in the case of payer data exchange, you might be you'll play the role as the new payer, and then you'll play the role as the old payer. Do the test twice, and then you'll just go through the whole test cases that way. Yeah, it'll be it'll be different and more complicated when you get to something like prior authorization, where the EHR has a specific role, and the payer has a specific role. So it'll a little bit more defined like that, but it's the same concept. Any other questions? Just a few more minutes left. All right. Thank you, Michael.
Thank you, Tim.
And thank you, everyone.